Direct Connection is made by MPT to serve all of our diverse communities and is made possible by the generous support of our members. Thank you. Live from Maryland Public Television, this is Direct Connection with Jeff Salkin.
Hi, everybody. Thanks for tuning in for Direct Connection. Coming up tonight, a summertime question about the neighborhood pool and why it makes your eyes turn red. A new report says it is not the chlorine. We will dive into that topic coming up. First tonight, a more serious story. Governor Hogan has begun treatment for non-Hodgkin lymphoma. More about that disease in this week's Your Health segment. Joining us is Dr. Arnab Banerjee, Assistant Professor of Medicine at the University of Maryland School of Medicine and hematologist and oncologist at the University of Maryland's Marlene and Stuart Greenebaum Cancer Center. Doctor, thank you for being with us.
Thank you for inviting me.
Let's begin with what lymphoma is. What does that mean?
So lymphoma is a blood cancer that is derived from a type of blood cell called a lymphocyte. A lymphocyte is a white blood cell, and normal lymphocytes in our bodies actually help us to fight infections. And so during an infection, a normal lymphocyte will multiply to make many lymphocytes, and when the infection is cleared, the excess lymphocytes will die off. And we need that balance. So what has happened in lymphoma is that there have been genetic mutations in a lymphocyte. And the result of these mutations is that that lymphocyte has lost control and become a lymphoma cell. And so even though there's no infection, it just multiplies and multiplies and never dies off. And so those cells just accumulate.
So we have white blood cells piling up.
Oh, yes. Mm-hmm.
Now, we hear about Hodgkin or Hodgkin's lymphoma or non-Hodgkin or Hodgkin's lymphoma. What's the difference?
So many things are different. Really, the only similarity there is that they are both cancers of lymphocytes. They're derived from the same type of cell, but the behavior of those cancers and how they're treated is very different. I mean, under the microscope, a Hodgkin's lymphoma, very few of those cells, a small percentage, are actually the cancer cells. The rest of the cells are just a screwed up immune response to that cell orchestrated by the cancer cell itself. Whereas in a non-Hodgkin's lymphoma, almost all of the cells in that tumor will be the cancerous lymphoma cells.
One of the really striking things about the governor's press conference a week ago today when he announced this diagnosis was that he said he felt fine. He didn't feel sick. And what he noticed was a bump in his neck when he was shaving. In the patients you see, how common is that?
That is relatively common. There are actually many ways lymphomas can present. And one of the ways is just a bump or a lump in someone who feels otherwise healthy. Lymphocytes or lymphomas tend to be in places where lymphocytes go normally. So in lymph nodes along the neck or in the groin or in the armpit, those are places where people are likely to find masses if they have a lymphoma. But lymphomas can also present with other symptoms like fevers or night sweats. Some people lose weight, although they're not trying to lose weight. And other things can be low blood counts. Lymphomas also go to the bone marrow, and they can also go to the spleen, where a patient might experience a feeling of fullness or heaviness in the abdomen, or another common symptom is not being able to eat a full meal. We call that early satiety.
Meaning that the spleen is pressing on the stomach a bit.
So large that the stomach can't expand properly.
I should emphasize that even though the governor is being treated at the University of Maryland Medical Center, you are not treating him, and we're not talking specifically about his case.
That's correct.
Certainly there is a high level of interest now in blood cancers as the governor goes through this process. And at the end of last week, he revealed that he was stage 3, not stage 4, which was good news. What does that mean? What's the difference?
Well, it sounds like what was being done was a bone marrow biopsy. And the real difference between a stage 3 lymphoma, which means the disease involves areas both above the diaphragm and below the diaphragm, so sort of the top half and bottom half of the body. The difference between that and a stage 4 lymphoma, in stage 4, other organs such as the bone marrow are involved as well. So from what I've read and what I saw, it looks like they were waiting for the results of that bone marrow test, and that was how they made the conclusion that it was stage 3.
Let me remind our viewers, if you have a question about lymphomas, perhaps leukemia as well, the blood cancers, give us a call. We'll have the number on the screen. You could also tweet your question. Our Twitter address is @MPTNews. We'll talk about treatments, but let me ask, if I can, a dumb question about treatments. So if it's an excess of white blood cells, is there a way to physically remove them? Take some blood out, spin it or whatever, and put it back?
That's actually not a dumb question at all. In fact, that is something that can be done in not so much in lymphomas, but in leukemias. In lymphomas, the cells tend to be socked away in the lymph nodes or in tissues, so they can't be pulled out in the blood. In leukemia, which is another white blood cell cancer, the cells are in the bloodstream, and we usually don't physically pull them out of the blood because they're multiplying so rapidly, it's impossible to remove every last one. But sometimes when a patient has a very, very high number of these cells in the blood, they can make the blood so thick that that patient is at risk for something like a heart attack or a stroke, just because those cells will clog up the blood vessels. In those patients, we'll sometimes do something called leukapheresis, which is kind of an amazing procedure where blood will be removed from the patient, the white blood cells will be spun out, and the rest of the blood will be returned to the patient.
Now, the governor is undergoing chemotherapy. I imagine that's a standard first-line treatment here. And the other thing, again, not talking specifically about his case, is that some of the medical professionals who have commented have talked about the incredible success rates of the chemotherapy treatments in resolving, at least temporarily, what seems to be a pretty dire situation.
Yes, and that's particularly true for the aggressive lymphomas, which actually sounds a little backwards, but that's one of the interesting things about lymphoma, that there are many different types of lymphoma, even within non-Hodgkin's lymphoma. And one of the first sort of categorizations we make is it an aggressive lymphoma or an indolent lymphoma, one that's slower? The aggressive ones, although they grow faster and can be more dangerous up front, tend to be more amenable to chemotherapy and tend to have reasonable cure rates, depending on the type, whereas the indolent lymphomas, although they grow much more slowly, are much more often not curable from the outset.
How important, if you have one of those, or whatever kind you have, but especially the aggressive, how important is it to get to a knowledgeable oncologist quickly?
Does
it help in a matter of days?
It does help, because there are actually many intricacies to lymphoma care. And while it's important to be seen quickly, and community oncologists can deliver most of the chemotherapy regimens that are required, I would recommend that any patient who is being diagnosed with a lymphoma seek a second opinion at an academic medical center, just to make sure nothing's being missed, to make sure we know exactly what subtype it is and that the correct treatment plan is chosen.
Do you frequently work in consultation with a community-based oncologist?
Yes, I've had the pleasure of interacting with many of the community oncologists in Maryland, and they're actually a very strong group of oncologists we have here.
Let's take a phone call. Harford County, this is Rich. Rich, thanks for the call. Go ahead. Rich, you're on. Go ahead. I think we lost Rich. The prevalence of this, who gets it? What do we know about demographics or age differences or any other trends?
So like most cancers, non-Hodgkin's lymphoma is more common as people get older. I think most of the patients I see are in their 5th or 6th decade of life or 7th decade, but it does span the whole spectrum. I have patients who are in their 20s and I have patients who are in their 80s. It's both men and women.
Anything that triggers it? I was reading about some types of infection are suspected.
There are some triggers that we know about. One of the strongest associations we know are with certain chronic viral infections. One of these is with the Epstein-Barr virus, or EBV, which is also the causative agent in mononucleosis. The other one is HIV. Patients who have HIV have a much greater chance of having a lymphoma.
Let's talk to Brant in Prince William County. Brant, thanks for calling. Go ahead.
Hello. My name is Grant Jacobson. I'm a survivor of non-Hodgkin's lymphoma. I had it in 2004. I was treated at the Naval Hospital at Bethesda, and I survived it, which I'm very grateful for. But one of the effects that of the chemotherapy was a peripheral neuropathy. Initially, it was so bad I couldn't hold a toothpaste or write my name with a pen in my hands, but that gradually cleared up. But it never, ever really recovered in my legs, and I have trouble with balance to this day, and they say there's nothing they can do.
Grant, thank you for the call. We'll get some advice. Best of luck to you. The governor mentioned when we were starting chemotherapy that it's brutal stuff. I mean, it's attacking your body in a sense.
And this side effect that Grant mentioned is actually relatively common. This is what we call peripheral neuropathy. And it's one of the drugs in particular, a drug called vincristine, that is used in many lymphoma regimens, has this side effect. Unfortunately, it's hard to get around it. There's not another drug that does the exact same thing, and this drug is very good against lymphomas. We do try to mitigate the toxicity as best we can. If a patient's having a lot of it, we'll often back off on the dose a little bit, or we'll use other medications to try to help them through it. There is active research going on in how to try to combat peripheral neuropathy, but right now it is still something that people can experience.
What's the reason that a patient might be started on chemotherapy as an inpatient in the hospital as opposed to stopping in at a local facility once or twice a week?
There are a couple of reasons a patient can be treated as an inpatient. One reason is if the regimen that is chosen is one that is a 24-hour infusional regimen, one that runs over a very long period of time, often that is given over a few days as an inpatient rather than as an outpatient. Also, in many cases, the first cycle will be given as an inpatient no matter what regimen is given. And this is related to the amount of lymphoma that is in the patient. When patients have a large burden of disease, they can undergo something called tumor lysis syndrome with the first cycle of chemotherapy, because the lymphoma cells will die very rapidly. And when this happens, all of the contents of those lymphoma cells can be released into that patient's bloodstream, and that can be very dangerous. So we give the patient lots of IV fluids and watch them carefully. We watch their blood levels of things like uric acid and potassium, make sure they don't get too high to a dangerous level until all of those metabolites come out in the urine.
Montgomery County, this is Steve. Steve, thank you for the call. Go ahead.
Yes, thank you for taking my call. I wanted to find out, in leukemia now, they're starting to use immunotherapy, but I note that in this non-Hodgkin's lymphoma that the governor has, they're using chemotherapy. Any chance they're going to, it's possible to use immunotherapy?
Steve, thank you very much, and that's your area of research interest.
That's something I'm very interested in. And well, different types of therapy are called immunotherapy. Some people would even call rituximab or Rituxan immunotherapy. That's something that's used in many, many different non-Hodgkin's lymphoma regimens these days.
And other cancers, right?
And other cancers, too. There's sort of more... There's been a lot of advances in immunotherapy recently, and some of them involve something called checkpoint inhibitors, which release the patient's own T cells against tumors, such as lymphoma. And there's therapy involving adoptive T cells, in which T cells are removed from a patient, manipulated outside of the patient, and then reinfused to fight the cancer. All of these things are being researched in lymphoma, but are not accepted therapies at this point. So the chemotherapy that the governor is getting, and chemotherapy in general for lymphoma, is the proper frontline therapy at this point. But there are clinical trials ongoing at places including Maryland that do involve immunotherapy.
Carroll County, this is Annette. Annette, thank you for the call. Go ahead.
My son-in-law was diagnosed with non-Hodgkin's lymphoma, and I was wondering what the survival rate is. He has had a bone marrow, and he's had drip chemo. So could you let me know what the survival rate is?
Annette, thank you. Best of luck.
Best of luck to you, Annette. So that survival rate, I'm not going to be able to give you an exact number because it's highly dependent on the exact type of lymphoma and also the stage it was at diagnosis.
This is one of those conditions, is it fair to say, that you're better off today than you would have been 10 or 20 years ago, but the horizon 10 or 20 years from now is dramatically different?
Yes, I agree. We are in the middle of a very exciting period in cancer therapy in general, but specifically in lymphoma therapy, where treatment regimens have really evolved over the last 10 or 15 years. And with the advent of things like immunotherapy and signaling inhibitors that are also being developed, there's going to be much, much more development. And I think that the cure rates will be much higher in years to come.
Good news. Dr. Arnab Banerjee of the University of Maryland School of Medicine. Doctor, thank you for your time.
Thank you for inviting me.
Appreciate it. Just ahead tonight, keeping that water in the neighborhood pool safe this summer. We'll be right back.
Tonight on MPT.
Find out next time which values have elevated to new heights on Antiques Roadshow Vintage Denver.
Oh my goodness, that's great.
No way! Oh my God, this is so cool. Thank you so much.
Can you guess what values went up, down, or stayed the same? Find out next time on Antiques Roadshow.
Tonight at 8 on MPT. Next time on Father Brown.
He who disturbs the appointed of the gods shall suffer their wrath.
An explorer's young wife is killed.
She spoke a name, Amenhotep.
It seems a mummy's curse is the cause.
Leave Amenhotep in peace, or you'll be next.
And when Father Brown investigates, he may be the next victim.
Of an unexplained death and a 3,000-year-old mummy on the prowl.
Father Brown. Tonight at 10 on MPT.
What's in store for this week's Chesapeake Collectibles?
He was the first Major League Baseball player to actually have his number retired.
The dragon itself is incredible.
A very high style indeed.
I'm the little girl in the blue dress.
This was actually found in a box lot at the end of the auction.
And he created things that moved, kinetic art.
I'm Rhea Feiken. Join me next time for Chesapeake Collectibles.
Thursday night at 8 on MPT.
Tonight on MPT2.
On Masterpiece.
Look to your liberty, cousin. A great many girls be glad to acquire the name of Poldark.
Mining, 'tis in the blood, your fathers say.
Would you like a wager? Would sooner gamble on a vein of copper and the sweat of 50 men than on the turn of a card.
Ross Poldark in love. Quite the spectacle.
You are a disgrace to the name of Poldark.
Stop it! Poldark. On Masterpiece.
Tonight at 8 on MPT2.
Joining us now in the studio, Terry Brown, Vice President at Buddy's Pool and Spas, and David Greisman, Media Relations Specialist at the Columbia Association. Gentlemen, thanks to both of you for being here. So the CDC, the Centers for Disease Control, put out this report saying there are two reasons that people's eyes get red in the neighborhood pool. There is number one, and sometimes there is number two. And you know what I mean by number one and number two. Surprised by this?
There are a couple of reasons that we have seen that people's eyes get red, and it can be for a variety of reasons. It doesn't necessarily have to be from somebody's body.
Back in my lifeguard days, which was a long time ago, I had heard it was the pH, not the chlorine, meaning how acidic the water was.
Right. The pH can definitely irritate your eyes. The typical pH of your body is 7.5 in the eyes, so that's a good range for pH in a swimming pool, somewhere in the 7.4 to 7.6 range. That's what you want to shoot for. That's going to be the most comfortable on your skin, hair, and eyes. And the other thing is what's called chloramines. So it's a form of chlorine, but it's a combined chlorine. So typically, if you can smell, if you walk into a facility or you get out and you can smell the chlorine, a lot of times that's not the good, what's called free available chlorine that's doing the work. It's really the chloramine.
I thought the smell of chlorine was sort of a reassuring smell. The opposite?
In many cases, yes. Yeah. If you have the chlorine at the right levels, it really should not have a strong odor.
All right. So, David, Columbia Association operates dozen or more neighborhood pools? How do you look at this?
Well, so we have 23 outdoor pools, and then we also have 6 indoor pools in 5 different locations. And with our outdoor pools, it's not really a problem with the chloramines. If there is an issue with any organic matter that's been mixing with the chlorine, often the air movement will take that smell and move it on. With the indoor pools, it requires a good HVAC system, some fans. One of our pools, we do have some UV lighting that then takes that organic matter and oxidizes it.
People aren't supposed to pee in the pool, but apparently people do. Michael Phelps, greatest swimmer of all time. A couple of years ago, he admitted in an interview that the competitive swimmers apparently all pee in the pool. How are we supposed to think about that?
Well, obviously, it's not something that we would ever encourage, and the bathroom facilities are supposed to be very close. But if it does happen, and you have the water chemistry set in the pool, it generally is a very large body of water, and the amount of chlorine in that water should sanitize that fairly quickly.
We have no way of knowing how many or how few people are urinating in our pools, whether it's adults, kids, or both. But
You're supposed to say nobody. Nobody ever does this in the Columbia
That's what
pools.
we hope. But even if they do, the chlorine levels keep our pools sanitary. We do monitor them every hour, and we make sure that our pools are sanitary. And of course, we do have bathhouse facilities, and we encourage people to use them.
Yes. There's always a sign, isn't there, that says everybody should shower before they get in the pool, and you seldom see anybody doing that. But that's an issue too, isn't it?
It can be, if especially if people have been walking in an area. I think especially in I deal primarily with residential pools, but I know in a lot of the commercial facilities, if you have a high use area, what people track in on their feet can certainly be a little bit of an issue, and anything, perspiration, can certainly contribute to the chloramines that are in the water. And again, the chloramines still have a sanitation effect, but it's not as strong as the free available chlorine, which is really what you want in the water.
Let's grab a phone call. Fairfax County, Virginia. This is Allie. Allie, thanks for the call. Go ahead.
Yeah, hi. I want to know how clean and how safe is it actually to go in a public pool? Because I've seen stuff firsthand where I've had to leave pools, and I'm just leery of it nowadays.
Thanks very much. Reassure everybody. Well, the good news is there's no sharks, right?
Well, again, we do monitor, at least in Columbia with our pools, we monitor them every hour. We do have highly trained staff, and we're making certain that the chlorine levels are there, that our pool is clean, it is healthy. You never want to, over-chlorinate a pool while people are in it. In terms of any other rare incidents that may happen, we do hope that they are rare, and you would, of course, clear people out.
Yes, I was thinking, should somebody be more concerned about the crowded neighborhood pool? 4th of July weekend, you have a ton of people. It's probably the peak weekend, but there are people there who are on top of it. Or the backyard pool where, it's sort of amateur hour a little bit. What kind of mistakes do people make?
Well, biggest mistake is neglect, and that can be in a residential pool or a commercial pool. We typically, with a residential pool, recommend the simplest way is what's called a 3-step program, and that is basically you're keeping chlorine sticks in the skimmer or in some type of feeder that is going to give you a residual of chlorine continuously all the time. And then the second step would be to add some type of shock or oxidizer on a weekly basis. And that oxidizes out and basically breaks free all of that, the chloramines that are in the system. And then the third step is the algicide to prevent any algae from growing in the pool.
Let's squeeze in one more phone call. George in Anne Arundel County. George, thanks for the call. Go ahead.
Thank you. Your guest has talked about an hourly test of chlorine that would give apparently a perfect test of what's going on, but does it really completely test for bacteria and possibly other pathogens?
George, thanks very much. Yeah, nobody's testing for bacteria on an hourly basis.
For bacteria, most of the bacteria that's out there is going to be killed
by the chlorine
almost instantly if there's a chlorine residual. So the chlorine residual, having a 1.5 to 3 part per million chlorine residual in the pool, that is what the EPA is really recommending. And at that point, they're saying there's very little bacteria. Obviously, it's not going to be zero, but there's very little bacteria that would cause any harm. There are some cases that where you can have a higher level. There are some bacteria that may take longer, but no, I'm not aware of any ongoing testing of bacteria in the water.
We may be out of time, so we're going to thank you and say good night, everybody. Thanks for watching. Take care.
Your health segments are a co-production of Maryland Public Television and the University of Maryland Medical System.
This program was made by MPT to serve all of our diverse communities.